That is correct.
And you would agree that when they passed, you were not a citizen?
That is correct.
I want to go through, let's just start with some basics. In your capacity as the medical director of the ICU at Mount Carmel, fair to say you would know how many critical care physicians worked within that facility between the years 13 and 18?
Yes.
And would you agree with me that it was 6?
It was probably more than 6.
Okay, tell me how many it was.
I think we had 6 daytime people and 2 nighttime people, so maybe 8 in general.
Okay, you know the nighttime would be Dr. Hagris and Dr. Husel?
Yes.
And then in addition to those 2 critical care physicians, there would have been 6 more.
6 critical care, but not in the ICU at the same time.
Okay, so in all of Mount Carmel West, between 2013 and 2018, there was 8 total critical care physicians.
Yes.
So, and just a general question, obviously 2,300 is not an accurate number as to how many critical care physicians were within that entire hospital during that 5-year time. Do you agree with me?
Yes, I'm not sure where the 2,300 came from. I apologize, but no.
Yes. Let's go through your direct if we can. You just generally said that people in ICU, and I wrote this down, but of course, tell me if I'm wrong, they're generally very sick patients. Would you agree with me on that?
Yes, ma'am.
And I know when you talked about your career path and how you came to Mount Carmel, but with respect to Dr. Husel, you understand, or you know from your own personal knowledge, that he did his 4-year residency in anesthesiology at Cleveland Clinic.
Yes, ma'am.
And then he did his additional year with respect to critical care medicine also at Cleveland Clinic.
Yes.
And then he was hired by Mount Carmel Hospital. Is that correct?
Yes.
In 2013?
That seems about right. Yeah.
And you talked about sort of the pathway, how you get to be a critical care physician. Do you remember that line of questions?
Yes, ma'am.
Your pathway, fair to say, was internal medicine.
Yes.
Dr. Husel's pathway is anesthesiology.
Yes.
Dr. Hager's pathway is internal medicine.
Yes.
And you would agree with me that there's not one other critical care physician at Mount Carmel West during this period of time whose pathway was the same as Dr. Husel's.
That would be correct.
He's the only one that's anesthesiology to critical care.
Yes.
I know we've now dated the meeting that you had with Dr. Swanner and my client, Dr. William Husel, as being in November of 2018. That sounds correct?
Yes, ma'am. It was the Monday after Thanksgiving holidays.
And you remember that, I assume, because you're vacation.
You remember vacations when you're a critical care doctor. Yes, ma'am.
You would agree with me that before you got that call from Dr. Swanner, that at no period of time in 2013 have you ever heard from a nurse any complaints with respect to Dr. Williams?
That is correct.
That year, no complaints in 2013 from any physicians about Dr. Williams,
That is correct.
or anyone in critical care, correct?
That's correct.
And even, again, different, I'll put from physicians, is you had that daily contact with residents, did you not, during this time frame?
Not daily, just when I was in the ICU.
Okay, and that's right, you kind of worked,
You rotate through.
rotate through. Tell me, doctor, if you recall, isn't it true that when Dr. William Husel was done with his shift, that you, as the medical director of the ICU, would know, that he actually then had to get together with the residents that were coming on shift and have a meeting?
Yes.
And he would do that as protocol, would he not? He would leave at 7 a.m. and confer with the residents that were coming on shift.
Yes.
And that conference, if you will, was it not, the purpose of it was to tell the residents about any events or issues that happened and or needed to be carried out.
Yes, pass along information, yes.
And you have no information that those meetings never took place, correct?
I'm sorry, can you ask the question again?
Sure. You have no reason to believe that that didn't take place as a matter of practice with Dr. Husel, correct?
I have no reason to believe otherwise, no.
So let me then go back to 2013. In addition to nothing from nurses or physicians or anyone in critical care, you also didn't hear anything from any resident in terms of complaints about Dr. Husel.
No, ma'am.
And then same group of individuals, nurses, physicians, critical care, residents, no complaints in 2014.
No, ma'am.
No complaints in 2015.
No, ma'am.
No complaints in 2016.
No, ma'am.
No complaints in 2017.
No, ma'am.
No complaints in 2018.
Except until the November thing, phone call, yes.
Right, you get the call from Dr. Swanner in November.
Yes, ma'am.
You were asked about whether or not Dr. Husel ever reached out to you with any questions. Certainly you made yourself available, right?
Oh, yes, ma'am.
And I remember during your interview with Columbus Police Department, when you talked about if there were issues with your dosing, that you would expect a pharmacist to give you a call if there are any issues. Do you remember talking about that?
Yeah, if there was anytime I make a mistake or, I mean, I'm human, I make mistakes or whatever, if something seems funny or I expect the pharmacist to reach out and let me know, or nursing staff to let me know.
And that was my next question. And you said that you expect the same of the nursing staff, right? If they see issues or problems with something you've done or ordered, that they would communicate that with you.
Right, the pharmacist's role is to be patient advocates and the nurse's role is to be patient advocates as well. Yes, ma'am.
And fair to say, doctor, that at your time at Mount Carmel, you rely on the fact that pharmacists and nurses are patient advocates.
Yes, ma'am.
I've got some questions about the pain discussion, about whether being intubated or extubated is painful. I noted that you said that being extubated wasn't painful.
It's a matter of perception, difference between pain and comfort, I guess, or uncomfortable. It's not the most painful thing in the world, but it is uncomfortable, I guess would be my answer.
And so I'm just getting a question. If I were to say, and I am going to ask you, that I have gone through an extubation and I found it painful, would I be lying?
I don't know you that well, but I'd probably say no.
You talked about palliative extubations and when making the decision to palliatively extubate. And I want to go through kind of the things you talked about on direct. One thing is you establish the relationship with the family, right? You talked about that.
Yes, ma'am, I think that's very important.
And so that would include, let's just say, if the extubation, the decision to extubate was made during the nighttime shift, that would, in your opinion, require Dr. Husel to speak with the families.
Yes, ma'am. Yes, ma'am.
And typically, I know you said your preference is to have peers there, nurses there,
Yes.
and even spiritual care staff and chaplains worked at the night, did they not?
Yes.
And they were often, during any kind of decision like this, would come and be with the family and spend as much time as needed. Is that fair to say?
Yeah, it's a very challenging and tragic time for everyone.
And which reminds me, I remember during one of your questioning or I'm not sure if it was your depo or your police department interview, but you were asked about being an ICU doctor, and you said it's a very demanding job. Do you remember saying that?
Yes, I'd say it today. Yes, ma'am.
Because it can be quite stressful.
Yes, ma'am.
And fair to say that those around you, right, particularly the family members, it's a very stressful situation for them as well.
Yes, they have no experience, and my job is to try to help them through the difficult discussions. Yes, ma'am.
And you indicated on your direct, I wrote down that when you were asked about the code statuses and the 3 statuses, when the decision is made by the family that it should be a DNRCC, that comfort is then your top priority.
Yes, ma'am.
Could you explain to the jurors the doctrine of double effect? As you understand it.
I'm not an I'm not an ethicist or whatever, but it's to, when you do something to someone, a patient, whatever, the goal is good, even though it may cause short-term problems. For example, if I stick a special IV in someone's neck, like a central line, that causes discomfort, but the goal is to have access for medications and support. Or same for intubation. It's uncomfortable intubating, so you know it's uncomfortable, but you're trying to save their life.
And so the good outweighs, if you will, the potential harm or bad that could happen.
I'm sure that's a definition. I've never really heard double effect that much, so.
You haven't heard it that much?
No.
Let's talk about those questions about whether a palliative extubation is ever an emergency. Do you remember that line of questioning?
Yes.
I mean, by definition, the process of a palliative extubation, once the decision is made by the family, takes some time, does it not?
Yes, ma'am.
Okay, so the physician places the orders, or I'm sorry, gives the verbal orders, right?
Usually you place them on the computer.
Okay, and then the nurse will facilitate the orders.
Whatever nurses do, yes. I don't know.
Okay, and I'm going to get back to you about whatever nurses do, but then there's a period of time between when the medicine is placed, right, and the medicine is obtained, and then the medicine is administered.
Yes, ma'am.
Right? So these questions about emergency, a palliative extubation by definition, wouldn't you agree, takes some period of time between when the decision is made and to when it is carried out?
Yes, ma'am. It can be hours, or it can be even a day or so, yes.
And I remember you talking about that it could be within an hour or it could be within 22 hours as to when it's carried out, right? And when the family makes it.
Right. Sometimes you have family members traveling or trying to get there, things like that. So that weighs into those discussion points as well, yes.
And you would agree with me that, as the medical director of the ICU, that one of the things that was a capability of Dr. Husel in his capacity during 2013 to 2018 was to oversee palliative extubation.
Yes, that would be his role as a critical care physician. Yes, ma'am.
And so I just have a question for you. If you're working in the ICU and let's just say someone makes a decision to change the code status of their loved one to DNR and CC, and a palliative extubation is impending. You don't necessarily kick it to the next shift, do you, just so that someone else can do it?
Your Honor, I would object to hypotheticals being asked.
It is sustained.
Tell me this in your capacity. Dr. Husel was hired to be part of the critical care staff, so doing palliative extubation was part of his job.
Yes, by the hospital, yes.
Right. There was no rule at Mount Carmel West that palliative extubations could not be done during the nighttime shift, correct?
That is correct.
And in fact, I guess with respect to rules, there was no maximum dosage with respect to fentanyl at Mount Carmel West between 2013 and 2018, correct?
Not that I was aware of.
And you have testified to this jury that you used morphine during your palliative extubations.
Yes,
And fair to say, in your personal knowledge as the medical director, that actually everyone else that was in critical care used morphine except for Dr. Husel.
I can't speak for the other practices. I didn't know it at the time. Just for my practices, I did.
Did you know of anyone else that was using fentanyl?
Objection, asked and answered.
No, he hasn't answered that one. Do you understand the question?
Could you just repeat it? I'm sorry.
Remembering back to that time frame, do you remember anyone else in critical care that was using fentanyl?
Not that I was aware of, but again, I didn't really talk to anybody else about their practices in general.
I want to talk a little bit while I'm on the subject about morphine versus fentanyl. You use morphine. Fair to say that morphine has a double peak.
Yes,
So it peaks and then it peaks again.
yes,
And if you know, fentanyl has just a single peak. Is that true?
yes.
And I wanted to be clear, because I got a little soft-spoken, but you testified on direct that you didn't use fentanyl as a practice because it had a negative connotation because of its street use. Is that fair to say?
Yes, it was responsible for a lot of overdoses, especially in the Franklinton area in general, yes.
But you obviously agree that there's a difference between kind of the street drug fentanyl and the medically used fentanyl within the hospital system.
Yes, my perception, but hang on.
And that's why you were talking about the negative connotation.
Yes, ma'am.
And so going back to this emergency line of questioning, I know during your this relevant time frame, 2013 and 2018, sometimes you would work late,
Yes, ma'am.
and it's
A lot of times I'd work late, yes, ma'am.
because it's just nature.
It's a job.
And would you work so late that you would go into the night shift?
I was completing the work, but yeah, I'd work 8, 9 o'clock at night, yes, ma'am.
And sometimes it's fair to say that you would actually work the night shift, picking up shifts or otherwise.
Yes, ma'am, occasionally.
And forgive me for these questions that I'm about to ask that might
Right.
sound stupid, but here I go. At the nighttime in the ICU at Mount Carmel, I'm assuming there's lights.
Yes, ma'am.
Lights are on.
Yes, ma'am.
Because there's lots of questions about the cover of darkness, and I just want to make sure that the lights are on during the nighttime in the ICU.
Yes.
And there are nurses there,
Yes.
and there are charge nurses there,
Yes.
and there are chaplains there,
Yes.
other spiritual care staff.
Just the chaplains, I think.
Okay. And the monitors are on, is that fair to say, at the desks?
And in the rooms, yes, ma'am.
And in the rooms, right? Things are on, things are alive in the ICU, right? Even during the night shift.
It's a 24-hour place, yes, ma'am.
Okay. And also in the ICU, wasn't it on the 4th floor at this time
Yes.
of the building? So it's not like it's in the basement under the cover of darkness. It was on the 4th floor.
Yes, ma'am.
You mentioned a number of times about how it's patient specific.
Yes.
And when I say it, fair to say your dosing practices are patient specific. Is that right?
Yes, ma'am. Within parameters, yes.
And how, when when determining what's an appropriate dose for a patient, give me 4 factors that you would want to consider when determining what's the appropriate dosage of an opioid, let's say that.
it'd be hard to limit to four, but I would say first is the disease process. What are they in pain in general? The second would be, again, brain. The brain is the key component, especially a lot of these are after cardiac arrests. The third would be age of the patient. Fourth would probably be liver and kidney function. And last not least would be family input as well too.
And what about things like tolerance?
You can't really measure, judge that. So tolerance doesn't really influence my input that much in my practice.
Would you agree with me, doctor, that two doctors with similar education and background and experience could have differing opinions as to how best to treat a medical situation?
Yes.
I think when you were asked about going back to palliative extubations, do you remember when you indicated that you were asked about whether you ever gave benzos, and you indicated that it takes 10 minutes for them to kick in? Did I write that down correctly?
Yes. Well, in general, we try to give approximately 10 minutes before in general.
And so if
I get benzodiazepine through an IV, it would take 10 minutes for that to have its desired peak effect on my body.
It can. It again varies from person to person. So it'd be a judgment call at the time of the extubation, whether you have to give more.
And just so we're talking numbers here, I get it in my IV and I die 75 seconds later, right? We've then got, what, 8.5 minutes until
Objection, Your
that
Honor.
medicine peaks?
Okay,
Hypothetical.
stop. Let's go sidebar. Ladies and gentlemen, let's talk amongst yourselves. Come on. David's here with news stories of the weekend. waiting on Sam, you ready? While she's setting up there, let's talk about something real quick. Over the next day or so, there's going to be an argument about the plexiglass. I know there are some concerns about it. So I want each of you to talk to David, what your positions are. I will not be able to take everything down. The battle is raging right now, okay? The question becomes is, what's the convenience? I would like to take down the glass in front of the witness to enable you guys to hear better, okay? The rest of it's up to you guys, because the audience, I'm not as concerned as you guys. So you guys have a talk, each of you, with David over the next day, okay? Express yourselves. If you got no opinion, say you got no opinion, okay? David will not tell me who wants what, okay? He's going to give me a summary of what's going on and any concerns, okay? Because this is about, I want you guys to be comfortable, I want you guys to be able to hear, okay? So that's the big issue with me. My own personal thing, I can persevere. But for you guys, that's what I'm concerned about. So you guys express to David what your opinions are, okay? Ms. Menashe, I'm sorry about that, but I wanted to get that public service message on.
Transitional questions, so I'm going to leave it, not to mention it's cross, but in your experience in critical care medicine, I get the benzo through an IV, 10 minutes until it gets its full effect on me.
Objection, Your Honor. This is once again hypothetical, referring to herself hypothetically if she were to give me this.
I think she's, okay, stop, it's my job here, okay? Both of you two. She's okay with her question so far.
Okay.
I'm sorry, could you repeat the question?
Takes 10 minutes to take its full effect, correct?
What, to take its full effect? I'm sorry.
The benzos that you were asked about on direct examination, you did.
It can vary from person to person and disease state.
Sure, but on your direct examination, you said in general 10 minutes, correct?
That for a generic ballpark person, sure.
I want to talk about vasopressors along those same lines. Palliative extubation, fair to say that you, before the extubation is done, the vasopressors are stopped.
Usually almost, you try to do it simultaneously at that point.
Okay. Would you agree with me? Tell us what vasopressors do, vasopressors do.
Sure. Vasopressors are medicines, usually epinephrine type of drugs. Most people are familiar with epinephrine, which help raise the blood pressure when blood pressure is critically low and the heart's not pumping very well.
And fair to say it's something that can help keep someone alive.
Yes, it's designed to keep them alive.
And so when it stops, if you know, in your experience in critical care, isn't it true that it takes about 1 to 2 minutes for the vasopressors to leave my system?
Yes, the onset is very quickly and the off is very quickly. Although I've been surprised at times when I stop the vasopressors, the blood pressure rises, and I have no reason to explain that physiologically sometimes.
And doctor, because isn't that kind of the phenomenon with medicine? Like anything can happen, right?
That's probably life also. Yes, ma'am, anything can happen.
Are you familiar, in your experience and capacity as the director of ICU, of what is called the discharge summary?
Yes, ma'am, I don't do them, but yes.
And if you know, does an attending physician do the discharge summaries?
Yes, whoever the patient is admitted to, it's their responsibility to do the discharge summary. Usually in the internal medicine side of things, it's the hospitalist, the person in charge of the patient in the hospital.
And Dr. Ralston, in your experience, in your capacity, just a guesstimate, how many times do you think you dictated a medical record?
I'm sorry, medical records, the whole thing.
Electronic medical record. Like how many times have you dictated an event that happened at a hospital?
Like a progress note or a consult or
There's no any entry you would put in. How many times do you put an entry in?
thousands? I would have no idea. Millions? I'm not sure.
Right, but isn't it true that every single time you enter an electronic medical record, whether it's a progress note or a consult, you always knew, did you not, that anyone that accessed that EMR next would read what you did?
Ideally, yes. I'd hope they would read it because I'm the consultant and giving advice.
I want to go through the patients if we could. I'll start from the reverse. I'll start where you ended. Showing the witness what's previously been marked as Joint Exhibit 11, page 18 to 20. Just want to make sure the jurors can see this, though. Thank you.
Kind of fuzzy on the outsides,
Okay.
but you're good.
Okay. Fair to say this looks like it relates to patient James Timmons, correct?
Yes, ma'am.
And with respect to all of the patients that you were asked about today, I believe there's 4, you have no independent recollection as to these patients. Is that fair to say?
That'd be correct.
And in fact, this is the purpose of dictating things like consultation notes or progress notes so that you can go back and refer to them.
One of the functions, I guess, legal function, malpractice, things like that, yes.
So we're relying on the medical records because you have no independent recollection. And I want to show you your notes on patient James Timmett, if we could. Fair to say that the critical care time was 118 minutes, as noted.
Yes.
Okay. And this individual comes in this is an overdose situation. Would you agree with me on that?
That was the presumption at that point, yes.
And right down here, it indicates while he is on the phone, he had, and what is that word? Describe that word for the jury, if you will.
He basically, his heart stopped.
According to the emergency department physician, correct?
I had gone down and saw the patient, and then I was coming upstairs to try to say, hey, let's get this guy up here quick. And the ER doc came and said, hey, his heart stopped again.
And his heart stopped again.
Or, let me see here a second. No, his heart, that was probably the first time it stopped then.
So, and fair to say, so he had cardiac arrest,
Yes.
right?
Yes, ma'am.
I'm going to go to second page where these notes are. And I'm sorry, just to be clear, this is your name here on this consultation?
Yes, ma'am.
Okay. Go here to the vital signs. Would you agree with me? It says noted and currently not stable.
Yes.
Okay. And then it indicates the blood pressure there.
Right. His blood pressure, the blood pressure is really 2 numbers. One is systolic, one's diastolic. In this case, his systolic blood pressure was low in the 80s when normal values are like 120.
You anticipated my next question. And then going to the third page of your consult, if you will, it's indicated that this patient was presenting after being found down for 48 hours.
Yes, ma'am.
And you would agree that that probably accounts, in your experience, for the fact that his glucose was at 29 because he had been down for 2 days.
Right. Down is a tricky term. It's used interchangeably sometimes. Sometimes in medicine, you think someone down, their heart stopped as being down. In this case, he was just laying there, not moving. His heart was still beating at that point.
Right. But we don't have an eyewitness as to what happened to him during that 48-hour period of time, right?
That's correct. Yes.
Okay. I want to go now to your last note here. Would you agree with me that you wrote overall prognosis is quite guarded at this point, and he is at high risk of undergoing another cardiac arrest?
Yes, ma'am. He had high potassium in his bloodstream, and we were setting him up for emergent dialysis, which was to remove the potassium from his bloodstream. So, yeah.
And showing the witness what's previously been marked as joint 11, joint exhibit 11, pages 31 through 38. Again, Dr. Wilson, does it appear that this belongs to the same patient?
Yes.
And if you could just see here the progress notes, does it appear that your name is on that document?
Yes.
Okay. I want to just go up here to this section right here. I'm going to zoom out a little bit. If you could, right here where it says positive, fair to say that's for cocaine?
Yes.
And is this second positive for, is that THC, what we more commonly know as THC?
Yes, marijuana.
Marijuana?
Yeah.
And so I'll ask you this, because if an expert or someone that reviewed this document indicated that the toxicology report was negative, that would not be correct. Is that true?
Yes, the toxicology report, urine toxicology reports does miss fentanyl or synthetic morphine type of drugs.
And then going to the second page of this document, again, the critical care 121 minutes, that coincides with the previous exhibit we saw. Is that fair to say?
I believe this is perhaps from the next day when I saw the patient
Yep, let me make sure.
on 10/23, I'm guessing. This is a guess, though.
Yes, you are right. So this is from 10/22. And so this exhibit we're now looking at is the next day.
Yes.
Okay, and fair to say then the next day, so the day before Mr. Timmons passes, the note in your progress notes, is it not, without the ventilator, pressors, and interventional critical care, patient would die or have organ damage?
Yes, ma'am. Without life support, life is no longer supported.
And then these are your subjective notes here. Is that correct?
Yes, usually the residents write a chunk of that note there. My note is mainly from above, where it says house officer's note reviewed and confirmed.
And this is your, these
That's
are your
my,
notations?
yes, ma'am. That's my note up in that section there.
And so the information with respect that the patient coded in the emergency department, these would be the residents' notes?
Right, which I reviewed as well, yes.
Tell me, doctor, would you, fair to say, you wouldn't have written this note right here about someone that could walk out of the hospital and potentially check himself into a rehab facility. Would you agree with me on that?
Not at that point, no, ma'am.
I want to turn now to James Allen. Showing the witness what's been marked as joint exhibit 8, page 17 to 19. Doctor, does this appear that it belongs to patient James Allen?
Yes.
And fair to say that it looks as if from the document that he was at Mount Carmel for 4 days approximately.
Yes.
This patient was 80 years of age.
Yes.
And you testified on direct about his jaundice, which is indicated right here. Does that show, that's evidence of liver failure, is that right?
His liver was not working well, is what that actually means, so yes.
Okay, when you turn towards the screen, your voice goes down. No, you're fine. Just keep enunciating louder, okay? Because it's human nature. When you concentrate, your voice goes down. So
Thank you.
And I know you had talked about this on your direct examination, but fair to say that Mr. Allen had a significant history of critical health issues.
Yes.
And going down here to the vital signs that are noted, it says, does it not stable, and he was on vasopressors, correct?
Right, he was on epinephrine type of drip to keep his blood pressure up.
And then I just want to go back to the consultation sheet. Did you see this section here where it says plan?
Yes.
Okay. And this is drafted, or this is dictated by you, is it not, Doctor?
Yes.
You indicate here that you discussed with his son right outside of the room. Do you see that right there where my finger is?
Yes.
And you indicate that you're very concerned, did you not, about his limited reserve given his multiple medical issues and limited pulmonary performance.
Yes, he had a bad heart and a bad lungs.
And then his son seemed very realistic when I talked to him about these things. That's noted in the plan, is it not?
Yes, I knew his son from before. I met him back in 2015 when I think I met him in the ICU back in 2015. And I think his son was a paramedic or a medically related person.
And so based on that fact, he had some experience with medical issues just generally.
He knew some lingo, yes.
And then I want to note this right here, is that you were the one, right, as noted in your EMR, that you discussed end-of-life issues with the son, right?
Yes, the patient was very sick and had dementia, so I'm not sure how much you would understand of those discussions.
But they clearly state they do not want to prolong the ICU course with trach and PEG if that ever occurs. Do you see that in your note?
Yes.
And then it goes on that you did talk to the son about what if it becomes a hopeless situation, correct?
Right. The plan was, in reading my note, was that we would try to fix the fixables. That's my approach to all the patients. I try to fix the fixables, let the angels take care of the rest, was the initial approach on this patient. And so therefore we were trying to fix what's fixable. If there's an infection, if we get his heart pumping a little better, if we can keep his kidneys working. But if it got to the point where everything starts shutting down, then it'd also be a heavy burden. And no one wants to talk to sons that love their father about dying and end life. No one likes those discussions by any stretch of the imagination.
Sure, and I just want to make sure that the jury knows that the date on this service record, when you just talked about the discussions with the son, is 5/24/2018. Does that look familiar, Dr. Ralston?
Yes, it was on 5/24/2018. I did that consult. Yes.
Okay, and the decision that his family made to palliative extubate him was a full 4 days later, correct?
That would be my presumption. I don't have evidence otherwise.
Showing the witness what's previously been marked as Joint Exhibit H, page 34 to 44. Again, same patient, James Allen.
Yes.
80-year-old male. Just want to, does this appear again to be your name on this note, Dr. Ralston?
Yes.
Just highlighting here, as of 5/25, would you agree with me, without pressors and critical care management, you indicated the patient would die or have organ damage?
Yes, that is a true statement.
Then going, if we could, page 43. This assessment down at the bottom of the page, is this dictated by you?
Yes, I think there's probably more to that.
Sure.
In general.
And then it goes up to the top of this page. Does that look familiar?
Yes.
Okay. And fair to say, right, I just want to get this down here. Patient with septic shock. Tell the jurors what that is.
Shock, there's many different types of shock. There is, for example, if someone gets stabbed, they lose blood, that's hypovolemic shock. There's distributive shock where you don't have massive infection, your blood pressure drops. But shock, the general definition of it is lack of blood supply to the end organs, the brain, the heart, the kidneys. That's the definition of shock. And septic shock is a very specific type where it's caused, low blood pressure is caused by an infection of some sort that's overwhelming the body.
And that can be a potentially fatal situation just in and of itself.
Oh, yes, ma'am. Absolutely.
I want to go to Ryan Hayes, showing you what's been marked as Joint Exhibit 2, page 16 to 18. Dr. Ralston, it appeared to be a medical record that belongs to Ryan Hayes.
Yes.
And this was another, was it not, overdose situation?
Unfortunately, yes.
And we could just go here. Again, this is your record, right? Dictated by?
Yes, ma'am.
According to her, the patient was not found down in water, but apparently, and then blank at that point. Did you see that?
Yeah. Yes, ma'am.
Tell me why you would have just put that blank there, or dash or underline.
Probably very similar to here. The person taking the dictation and typing it couldn't understand me.
And then you go on to say, as typed, do you not, that the individual that found Mr. Hayes was unsure how long he was down, but it could have been as long as 5 to 10 minutes. Do you see that?
Yes.
And you noted during your direct examination with respect to the brain without oxygen and how long that takes to have an effect. Do you remember that line of questioning?
Yes, ma'am.
Okay. And the number of minutes that you said on your direct examination was what?
It varies from person to person. It can typically 4 minutes is the criteria that we use for brain damage.
And this situation, just based on your medical record and the information you were given, was that he was down from 5 to 10 minutes.
Yes, my suspicion was probably longer though, given the cerebral edema.
And I'm gonna, let's talk about that a little bit. I want to go here before we do to this sentence right here. According to both Lisa and his brother, they clearly stated that the patient was very adamant about never being on life support, and they would not want to continue at this point. That's what the medical record indicates, does it not?
Yes, ma'am.
And then is this discussion about the organ donation, right?
Correct. The family was torn at that point, trying to decide what the patient wanted versus they knew he would want to also donate organs.
Right. And so they've got this patient doesn't want to be on life support, but donating an organ is important.
Yes.
Okay. But, and then you talked on your direct examination about the 3 options at that point, right?
Yes.
So that whether or not to facilitate the organ donation. I want to just go down to here about, you were asked a lot of questions. And I want to be sure to be as accurate as I can. About whether or not he was brain dead. Do you remember those line of questions?
Yes.
And you indicated that a CT scan was done?
Yes.
Let me find that patient. I want to make sure that we get the exact words out as to the finding of the CT scan. Fair to say that the exact words were that the CT of his head demonstrated very diffuse brain edema. Correct?
Yes.
So this is a serious situation here.
Yes.
And then with respect to the next page, so that's what the CT says. So that's the visual of the brain. Would you agree with me on that?
The anatomy of the brain at that point, yes.
And then you do this physical examination to see if there's cues that you can pick up from an examination to either support or refute the CT scan.
In conjunction with the rheology findings, yes, to see the extent of the brain damage. One's the anatomy of the brain, one's looking at the function of the brain, higher brain and brain stem at that point.
And you do that, and you know, this is when you talk about he does have bad doll's eyes.
Correct.
Okay, and that's an expression, as you testified to this juror, that you use, but it's certainly a cue that tells you that there's evidence of real brain damage. Would you agree with me on that?
Yes, the neurological exam would be very, very consistent with extensive brain damage, as with the history of the events that occurred.
And then, in line with that, you write down here, assessment and plan, do you not? I did discuss with the family that I am concerned about the severe brain injury that he has experienced and likelihood that he may progress into brain death.
Yes, ma'am, I was concerned about the brain damage and progressing into increasing cerebral edema, which can lead to brain death.
I remember during, I think it was your deposition, that you were asked these questions about brain death. And isn't it true that in your experience, that you have often found that lay people use brain death or think of brain death in a more expansive way than is the true definition?
I think sometimes when you tell people about brain injury, they assume that the patient is brain dead, and so sometimes I have to correct that misinterpretation of what I'm trying to tell them. They're under stress, so they may not hear it very accurately.
And I think this goes back to the point that sometimes you might say one thing, but in your experience, given the stress and the trauma, that it could be perceived in a way that you perhaps might not be intending.
I intended it a certain way. What they hear and perceive is different, I guess, would be my statement.
That, right?
No, but you can keep going back over it, asking them what's their perception, what's going on, and try to get a good feel for what they're understanding.
Sure. But in Ohio, and so we're clear, if someone is brain dead, then they're pronounced dead. Is that correct?
Yeah, it varies from state to state, surprisingly, but in the state of Ohio, yes, if you are brain dead, you are legally dead.
That's it. And so there would be no decision have to be made whether you palliatively excavate somewhere or not, because you would be pronounced dead.
We don't use that term for brain death. We just, they've died. And so at that point, and sometimes that's a blessing for the family, because that way they don't feel like they're thrust into this decision-making role.
And it relieves them of that decision. Right?
The burden, yes.
This is a good place to break.
Sure, Judge.
Okay, ladies and gentlemen, I'll give you 5 extra minutes to start back at 3:15. Okay, have a wonderful break. Remember the admonitions. And be gentle on David talking to him, okay? I know you all want to talk right away. Give this man a little bit of time. Okay, doctor, remember the admonition, you can go ahead and step off. Mr. Zion, anything for the record?
No, Your Honor.
Ms. Menashe,
Yes, Judge?
anything for the record?
No.
Okay. 15 after.
Oh, okay.
Yeah.
Just the 3
site discharge summary.
You want it? Oh, this one is due. I'm gonna write it here. No,
Hey guys, sorry, I am back. So I apologize. Want to poke my head in real quick. Yeah, so if you notice, we're starting to find out some things. Like a lot of these people actually might be dead technically. So you necessarily can't kill someone who's dead. And even if they're not and they're close to that edge, I think a jury's gonna say like this guy's not doing anything wrong. So I think this once again, this is just a little bit more, just pulling that string a little bit more, a little bit more, a little bit more, a little bit more. And I think it's gonna fall apart. At least that's my thoughts on it. So I had to catch up at 2 times speed, so that was interesting. What are your guys' thoughts so far about this? Like I said, it's not the prosecution that I've been worried about, but what the defense does. What are you guys thinking so far? Curious to hear your thoughts. Yeah, I saw that. We're back at 3:15. I was finishing something up, and then I had to catch up with some of the cross. But yeah, it sounds like he was offing people who pretty much were dead, if not already dead. And yeah. I think this is just the beginning. You know, I can only imagine how many more weeks the prosecution has of these doctors who are going to admit, well, yeah, it really wasn't that big a deal. Yeah, it's good cross-examination. And I numbers man, I don't know. I forget if you've been in here before, but anyways, thanks for being here. You know, like and subscribe if you haven't yet. You know, remember, good cross-examination doesn't have to like blow somebody up like a burning Russian tank. You just have to just start pulling it apart, start making them backtrack. Because once they backtrack, they lose credibility. Yeah, I think this shows that a lot of these people were actually technically dead. They just hadn't been declared dead by a doctor. But remember, Matthew, you are. I caution you to think about this way. You are somebody who's very focused on this. You are sitting here voluntarily watching a trial. These people are not, and these people are lay people who generally don't have knowledge of what's going on. Generally, like if you showed up and you told me you watch trials for fun, I probably wouldn't put you on my trial. I'd probably kick you off my jury. I don't like that. I want somebody who isn't coming in with what they think should happen or how it should happen. So remember, these are kind of just a bunch of normies, as you know, the kids say nowadays. A bunch of normies who don't do what we're talking about for fun. But yes, I agree, Rennie. We're at we are heavily into doubt territory, and I don't think they are really going to be able to get out of that. But you never know. You never know. So it sounds like a couple doctors here and there had used amounts of fentanyl, Shannon, outside of the OR, but in the OR you're going to use tons of it. So that's out of comparison. But as much as they want to say no, it sounds like other doctors have used it. They have used a lot of fentanyl before, just maybe not as much as him. But once again, that's why I don't know if I've said this on here, but I tell people when you're in a courtroom, always and never are very dangerous words because think about it. It just takes one instance to prove always is not correct. And it takes one instance to prove never was incorrect. And then what happens? Well, it makes it look like you either don't know, you're oversimplifying, or you're not necessarily being 100% accurate. So you have to be careful about using those. So, I mean, that's where I'm at. Where this I'm looking at it. Yeah, I'll be sticking around for a little bit. I've got a little bit of a break, so I can hang out and play with you guys for a little while. Yeah, the Suitcase Murder, I definitely want to do. That one, God, I think I already had that one marked down. That's, I'm glad that you guys have already planned shit out for me. I mean, I appreciate that. I'm just kidding. I'm giving you guys a hard time. Yeah, the Miller trial starts last week in April, and then Sarah Boone starts May 16th, unless that's changed. And I hate to say this, guys. If it comes down to Sarah Boone or the hazing one, I think I might cover the hazing one. I think that's Sarah Boone's got an awesome defense. He put himself in there. Sarah Boone's defense is beautiful. I didn't do it. And does she have a duty to help that guy? Now, yes, that might make her look like a cold-hearted bitch, but she doesn't have to help. She didn't put him in there. So, so good
Told
news.
you it was an obstacle course.
Canadian convoy organizers are finally getting out of jail after weeks on end of being held. So that's good news. I was following that along on Twitter while I was working on some things. Move my phone from speakers.
Jurors coming out of the room. Anything for the record, Mr. Zion?
Oh,
Mr. Nashi?
I don't have any sound going right now.
Mr. Nashi, anything for the record?
What the hell? Is that better, Rennie? 'Cause I still can't hear a damn thing. Oh, there we go. I can hear stuff now.
Sorry. I got an extra one up here.
You're clicking. Man. I wish I could be like Jose and have that swarthy hair that doesn't go gray, but deal with what you got. Look at Husel. This is Jose Baez is all fired up and ready to go. Husel looks like he's been through it already. When do you guys stand up when the jury comes in? I'm just curious. Like, how into this do you guys get?
Ladies and gentlemen, the jury, I hope you had a wonderful break. We're going to continue on with the testimony. Mr. Nashi.
Thank you, Your Honor. Just closing out the line of questioning with respect to Joint Exhibit 2, page 16 to 18. Doctor, this This consultation note appears to be from 4/2. Would you agree with me on that?
Yes, ma'am.
And again, the discharge date as noted is 4/4.
Yes, ma'am.
And as indicated, this last line here says, likely he will require brain death testing tomorrow, correct?
Yes, ma'am.
So in 4/2, that was the state of peril that this individual was in.
Yes, he was very brain injured, but not brain death at that point.
I want to move now. Did the prosecution have you, in advance of today, review Mr. Hayes's medical records as a whole from 4/2 to 4/4?
Mainly my role in the physician's progress notes, things like that.
You would agree with me, would you not, Dr. Ralston, that with respect to Ryan Hayes, the family actually made the decision to palliatively extubate Mr. Hayes during the day shift?
I don't recall that. I'd have to look at the records again.
One moment while I get something to refresh your recollection, and I will move on in the meantime.
My partner was on the next day. I did not see the patient the next day.
I want to move to the next patient, Ms. Belisari, showing you what's previously been marked as Joint Exhibit 1, page 126 to 1-2-3-4. Or I'm sorry, 1 through 4. Doctor, does that appear to be medical records belonging to Joanne Belisari?
Yes, ma'am.
And just so we're clear, that's your name on that medical record.
Welcome,
Is that
Seabreeze.
true?
Like and subscribe
That's
if you enjoy your
correct.
time here.
When I go to page 2 of that, right here, I want to just say, discuss the record that you indicated under comments. It says, does it not? Discuss with sister at bedside. Discuss with them the fear that she may eventually tire out and require intubation. Do you see that?
Yes.
And this note is from 4:30?
Yes. Again, this, I apologize, it's a format that I'm not used to seeing. I'm
Sure.
used to seeing on computer, so.
Sure. And so if I could just orient the jurors with respect to timing, this indicates it's 4:30, and based on the admit date, she had been at Mount Carmel for, let's say, 8 days-ish. Does that sound right?
Yes.
And her discharge date, assuming that's the date she passed, is a full 11 days later on May 10th.
Yes.
Going now to hand. This sentence right here, page 3, that sentence right there that starts with intubated, what did you indicate in the medical record right there, doctor?
She was intubated on life support and blood pressure support. Cachectic is a term that means she looked like she had lost weight, or looked thin in general.
And she's on full life support, it is noted in your medical record, correct?
Yes.
And when we see house officer, based on our prior discussions, we know that's you.
That's the resident,
That's the resident.
young doctor. The old term for him was house officers because they spend all the time in the hospital, so they were in house or whatever.
So would you agree with me that this note right up here indicates critical care 42 minutes, without ventilator or pressors, patient would die? Do you see that note?
Yes.
And I remember you testifying on your direct examination when you said, because without life support, there is no longer life supported. Do you remember that?
That would be correct, yes.
Let me go back to Mr. Timmons, if I could. Sorry to jump around, but were you, doctor, on the critical care committee
Yes.
during this relevant time frame?
Yes.
And did the Code Blue committee report to the critical care committee?
Yes.
I want to ask you about codes then, and what you would know about the coding process at the hospital. Tell the jurors what a code blue is, based on your experience.
Sure. Code blue is a alarm that basically overhead. You've probably seen on Grey's Anatomy or whatever. There's a code blue that's called out. That means a patient's heart has stopped somewhere in the hospital, or even somebody needs help. The ICU physicians and or residents come into the room. There's pharmacy that comes. There's anesthesia that typically comes. There is nursing staff. ICU nurses come and respond. And you try to, following American Cardiology's recommendations, you follow what's called ACLS, Advanced Cardiac Life Support, and you try to get the heart restarted by beating on the chest, by ramming a tube down the throat or placing a tube down the throat, and shocking the heart if the heart rhythm is one you can shock and bring back.
By analogy, in your experience in critical care, if you're on duty and the blue light or a code is called, and you're the physician, are you essentially the orchestrator?
It depends. Multiple people are qualified to lead a code or follow ACLS guidelines or ACLS qualified. The house officers a lot of times run it. I try to intervene if they're making a mistake or not thinking of something. But yeah, either myself or the house officers or even the hospitalist can actually run a code blue as well, or cardiologist, for example, as well.
And we know from your testimony on direct that after 2013 to 2018, residents or house officers didn't work in the night shift, correct?
That is correct.
Bless you, Sam. So just want to show you, again, going back to Mr. Timmons.
Your Honor, I would object that this witness was not present for these medical records.
Okay, let's go sidebar here on this one. Get to know each other.
Maisie Starr, thanks for coming in. Oh, we're back.
Sidebars are not my favorites. I'll ask a different way.
I won't take it personal, so it's okay.
And we've known each other too long, so you can't. This, Dr. Ralston, with respect to Mr. Timmons, you indicated that you reviewed the records with these patients that related to you. Do you have recollection as you sit here whether Dr. Husel performed any codes on Mr. Timmons?
Object, Your Honor.
She can answer that one.
Kenny?
No, there's obviously several codes throughout the year in a hospital from many years ago. I would not recall that.
And so I remember
Numbers man, yes, that's exactly what's happening.
Fair to say that some people survive them and some people don't.
Yes, that would be a true statement, yes.
I want to go to the issue, some general issues. Let's talk about overrides. I know you stand on your direct that the nurses do what the nurses do.
I'll show you override.
And same thing with respect to overrides. Dr. Ralston, you, during this relevant time frame, 13-18, had no idea about overrides.
No.
And so it would surprise you to know, would it not, that let's say during the year 2017, there were over 36,000 overrides on the ICU floor at Mount Carmel West.
I wouldn't know what's normal or abnormal. That's a pharmacy and nursing thing. I would not know whether that's high or low.
I want to talk about order sets, showing the witness what has previously been marked as State's Exhibit 17A. Dr. Wilson, does this look familiar to you, this document at all?
Yes.
Okay. And what do you know this document to be?
It is the terminal or compassionate extubation order set.
Fair to say that during your interview with Columbus Police Department, you were asked about whether you use order sets, correct?
Yes.
And during the years 2013 and 2018, fair to say you did not use order sets?
Typically not, but I did forget about the residents. If the residents were on, sometimes I'd show them it and show them what's on it, things like that.
Right, but you, in your care, when you decide, when a family decides, and you were overseeing a compassionate excavation, as you have told yours, you weren't using an order set, correct?
That's correct.
I want to talk about, going back to this point about the nights. I think we talked about what it looks like visually at the hospital at night. Wanted to ask you about the convenience, and that word seems kind of gross to use in this context, but you would agree, would you not, that actually sometimes it's more convenient for families to do a nighttime palliative excavation because of scheduling, would you not?
Convenient in the sense that perhaps in the early evening or late evening, I think it's
Convenient to kill
challenging
someone.
I'm not necessarily thinking that well at 2 o'clock in the morning sometimes. I think it'd be hard sometimes for families to be that early in the morning.
Sure, but when I'm a family making a decision to palliatively excavate and it's 8 or 9, then in the nighttime, and I know you were asked this during your deposition, it can give an opportunity, right, for people to come in from out of town because you want that.
Yes, ma'am.
And so, and also in terms of, I asked you whether there were any rules against nighttime excavations, and we know there weren't.
That's correct.
I want to talk about the number of compassionate, as you call them, extubations that you've done. I know in your direct you testified that with COVID, you're now hovering around 1,000 a night.
Right.
Yes, we'll
It's a
make it an
guess.
exact number. But fair to say, when you were deposed in 2020, you gave an estimate that maybe you did around 20 or 30 a year. Do you remember being asked that question?
Yes, but again, these are guesses. I have no idea.
Sure. And I just want to kind of give that.
And I apologize. I thought that it was over my career, not just in that time frame.
Okay. So between 2020 and now, you've done how many palliative extubations?
I'm sorry, between 2020 and now?
Yeah.
I don't know. Way too many, I guess, with COVID. It's been devastating. We're probably doing maybe 50 or 60 a year. Personally, myself, not just my partners,
Sure.
but probably 50 years or so over the past year.
Okay. So, and that's not my forte. So, an estimate, not believe it, 1,000 over your career. And tell me again the number of years of your career.
1997 through 2022, so it'd be 25 years.
Okay.
Well, excluding my fellowship training, which is additional 7 years, so gosh, 32 years.
Okay. And I had just done the math on 25. Okay. So it's about 30 plus a year. Does that sound about right?
That sounds a guess. Yes, ma'am.
Okay. And if you know, as the director of the ICU at Mount Carmel West, does it sound about right that in Dr. Husel's 5 years, he did just 35?
That would not seem extreme to me, no.
just a few other questions, Doctor. During your deposition, you were asked about the IV guidelines. Do you remember that?
Yes, ma'am.
And whether you were familiar as of 2020 with the IV guidelines, and you indicated that you were not.
No, ma'am.
No.
I was not aware.
One moment, Your Honor.
Seabreeze, that was my dog.
I forgot to ask you, Doctor. When you were asked about these order sets, and I'm just showing you as an example, State's Exhibit 17A, do you remember referring to these order sets as checkbox medicine?
Yes, I think when you're doing a very difficult approach to medicine, you try to take into account the patients, the family, all these other variables that come into play. I want to give the best care to that patient, even if I'm compassionately extubating them. And I don't like people getting the habit of just using the same thing without thinking about the patient as an individual in general.
And I remember you saying in one of your statements that the human body is an amazing thing. Do you remember saying that?
Yes, ma'am. I think it is.
And to that end, I wanted to ask you about the conversations that you have with families when they're making the decision as to changing the code status and palliatively extubating their family member. Fair to say that you talk to the families and you tell them that once their loved one is palliatively extubated, that the patient could last moments,
Yes.
they could last minutes,
Yes.
hours, days,
Yes.
and you would agree with me that even moments could be less than minutes.
Yes.
Nothing further.
Redirect.
I didn't have any good from the 17A. Okay. That's it. Thanks.
Still have one on the screen.
Oh.
Doctor, on cross-examination, directing your attention or redirecting your attention back to what Ms. Menashe said about the total number of critical care patients or critical care doctors at Mount Carmel West.
Yes.
And she referenced a number of 2,300. That's not correct. You said you didn't know where that number came from.
That is correct. I know most of the critical care doctors. Yes, sir.
Right. Is it fair to say that within the 4 hospitals, you are aware that Mount Carmel has 4 hospitals in its chain?
Yes, I practice at 2 of them, actually.
Okay. Is it fair to say that there could be up to 2,300 physicians with prescriptive authority within those 4 hospitals?
Yes, that'd probably be reasonable.
So if there's a number.
He's a big dog. He's a rescue. We don't know what he is.
Prescriptions for things like fentanyl.
The barking
and
kind.
Midazolam.
Objection as to speculation.
I think you can answer
I'm sorry, could you re-ask the question?
So if there is evidence that there is approximately 2,300 physicians in the Mount Carmel hospital system, the 4 hospitals, those doctors would have prescriptive authority to write prescriptions for things like fentanyl and midazolam.
Not all of them.
All right. Directing your attention to Ms. Menashe's line of questions regarding complaints about Dr. Husel in 2013 to 2018. And so you became aware in November of 2018. Did you have any knowledge of his dosing habits during palliative withdrawals in the nighttime at the ICU?
No, sir.
Had you at any point become aware through any of your review of anything that went on in the ICU at night, that he was giving 1,000 micrograms of fentanyl in an IV push to patients in the ICU during palliative withdrawals?
No, sir.
Referring back to the line of questioning regarding the pharmacist call, you said, I'm a human, I make mistakes.
Yes.
Yeah, so have you ever added an extra zero onto something, for instance?
I'm sure I might have, yes.
Is that the type of thing you're referring to, making a mistake, a pharmacist calling you?
Yeah, or either the dose or the type of medication, or hey, this patient's allergic to this, or there's this drug impacts that drug. Are you aware of that? Those are important patient safety issues. Yes.
Okay. When you were saying about when the decision's been made to compassionately extubate somebody after this planned event with the family, you say you entered it into the computer. Tell us about that. What does that mean? Can you describe that more fully?
Sure. What I do is I basically just the computer component. Is that correct?
Yeah. Tell us how you do that.
Okay, I would just sit down in front of the computer. I would put the order in. I'd make sure that the DNR CC is put in at that point. I would make sure that the medications have been entered correctly. I would probably, I always go to the bedside nurse and say, hey, I put in these orders. When the family's ready, let me know. We'll get things going or whatever. Let me know of the timing so when I need to come back or usually I don't leave the ICU in these circumstances.
So there's no rush.
No, there's no, I'm trying to make sure that of all things, make sure these orders are put in correctly, yes.
Okay. Referring to 17A, which was just up there, this has been identified as the order set for palliative extubation. It's called terminal ventilator withdrawal. Is that another word for what you call compassionate extubation?
Yes, that is correct.
Okay. And you testified with Ms. Menashe that you don't like using, or you refer to this as, what was it, cookie cut, push button?
Checkbox.
Checkbox.
I was raised in the era of we actually wrote out every order and thing, so.
Okay. Well, let's look what's in the order set compared to what you testified as your general practice. What is, referring to medications. What is the range of medications that is on this order set?
One, the first morphine order there, the 10 to 5 dose, one's 10 milligrams or one's 5 milligrams. That's prior to take the breathing tube out.
And that's a case by case, that says PRN situation?
That's the second orders there where it says morphine, the second morphine order, the 1, 2, 3, 4, or 5.
Okay. So this would be what the order set would call to start with?
That's prior to taking the breathing tube out. Yes, sir.
All right. Is your practice in line with what the order set is?
Objection, Your Honor, be on the scope.
She showed him this.
Permit it.
I'm sorry?
I'll permit it.
Oh, thank you.
Yeah, that's a good one.
Yeah, it's a little lower than what the order set says. Yes.
What's a little lower?
My use of the morphine.
You actually use less than this.
For the prior to extubation, yes, but afterwards, that's about what I would use in the first hour.
So this second, I guess in medications, it would be the third check box down.
Right.
This is the PRN stuff?
Right. I'd use 2 milligrams every 15 minutes for any perceived distress from the patient.
Okay. And that's what that inject Q 15 minutes, that Q means?
Q means every 15 minutes as necessary for shortness of breath.
All right. And this
Right, and then after that first hour, you can see if they need more.
All right,
That's the third morphine order.
that's down here.
Yes, that's if you see comments after the first hour after the endotracheal tube or patient's extubated withdrawal.
Okay. And it goes on. What about Dilaudid? Per the order set, do you give Dilaudid and morphine together?
I'm sorry, I can't quite see that. I
I'm
apologize.
sorry. It's on the second page.
You don't really need two classes of the same narcotic.
Okay. And is it ever been your practice to give, and Dilaudid, another word for that is hydromorphine, that's the generic of that?
Yes, sir.
Has it ever been your practice to give both morphine and Dilaudid together?
No, because they're both narcotics.
Okay. So what's this next checkbox mean versus what you do? This down here.
Direction, same direction, Your Honor. You want to go to what he does?
Okay. I'll note the objection overruled. But you got this thing all open up, you can't see what you're referring to.
Gosh, Judge, I'm not
Thank
right
you.
here.
I was going to ask that.
I'm talking about this right here, pointing to the middle page of the second page of 17A.
That is for morphine drips, which is a slow drip of morphine into the vein continuously instead of pushing it in all at once.
Guys, the lag cleared up after a
And
while.
this is another thing that can be checked.
Yes, it's bad.
And what does
Okay.
titration mean?
Basically, it's to adjust the medicine up or down based on the patient's symptoms.
Okay. And then after the morphine, there is this Versed section.
Yes, that is correct. If you bring it down just a little bit,
Oh,
see the first
sorry.
one there.
And so the Versed, or also known as midazolam, is also on the order set, and I think you testified that it is also your practice to give a dose of Versed.
That is correct.
And it starts at 2 milligrams per the order set,
Yes.
and is that your practice as well generally?
Yes.
All right. And then it goes on to explain how Versed, is that fair to say, gets continuously given?
If you could pull it down again, I apologize.
Yep, sorry.
Yeah. Yes, if the other one is Versed for a Versed drip.
Okay. And the drip is the bag of,
A bag of fluid with Versed, the chemical mixed into it, dripping into the IV.
and is that slower than pushing it in all at once?
In theory, you have less of the dramatic effects that way. It'd be slower effects, or slower of the side effects that way.
And what side effects are those?
Objection, Your Honor, beyond the scope.
Sustained on that one.
What about oxygen therapy and the order set versus what you do?
Yes, you tip.
She asked about the order set versus what he does, Judge.
Right, I'll give it 3 on that one. You're not getting an opinion, so.
You place the patient on the nasal cannula oxygen. You might see people at the grocery store wearing the plastic tubing in their nose. And that's mainly for comfort a little bit. Oxygen is actually a drug, and it does provide some comfort at the end of life as well.
And it's on the order set we see here in 17A. Is that also your practice?
Yes, I have to put in, I always put in specific how much oxygen. The order set doesn't address that, so I always put in how much oxygen I want them on in general.
Because you don't want to do this checkbox medicine. You're looking at your patient.
I've been asked and answered several times. You would strike the questions granted.
All right. Ms. Benassi asked you, she said, can you give us 5 of the factors, or 4 of the factors that go into dosing, your dosing decisions for patients during palliative extubations? And you said, well, I don't know if there's 4, there's maybe 5. Do you remember that?
Yeah, there's probably multiple beyond that.
All right. My hearing's not so good. I got number 2 is brain.
Yeah, what's going on with the brain in general? Is it damaged? Is it even capable of perceiving pain at that point?
Okay. So with Ryan Hayes and his brain being damaged that Ms. Menashe talked about, did he need more pain medication or less pain medication based on what you saw when you saw him and when you laid that note?
He required less pain medication or no pain medication at that point.
I think number 3 was age.
Yes.
So we saw in these examples of the patients that you cared for, some of these folks were very, I have to be careful, they were elderly. Some, I believe Mr. Allen was 80.
Yes, I like to say older, not old, is what I always say.
And I understand that now as I reach those ages here. So how does that affect pain dosing? If someone's older, do they get more of it? Do they need more pain medicine, or do you give them more pain medicine? Or is that something that in fact is giving them less pain medication?
Direction, Your Honor, beyond the scope.
Well, you did elicit it. I'll permit it.
As you get older, you need less pain medication in general because the older brain doesn't handle it quite as well.
I wrote down number 4 of the factors of the 5 you gave, liver/kidney function. Can you explain why that is a question or something you would like to know determining whether how much pain medication someone requires or you prescribe?
You want to make sure to that even if you give the pain medications, you want their liver to be able to clear it at least, or the renal function not to let it keep accumulating is the biggest fear.
So if someone's liver and or kidney function is compromised, as we saw in those patients that Ms. Menashe pointed out, does that mean they should get more pain medication?
In your opinion, we've gone through this.
That's the way your question is. She's right. Sustained.
Based on your experience with these patients, if their liver function was compromised, if their kidney function was compromised, on your experience, would you give them more pain medication or less pain medication?
In my practice, I would wind up giving them less.
What was number 1? Do you recall? And I'm honest, I just didn't write it. I was trying to write it down. I think brain, age, liver, and then family. What was number 1, if you recall?
I thought it was brain, so I apologize. I'm not sure. I think disease process is what I put in there, disease process.
Disease process. What does that mean, and how does that affect your decision on dosing levels for pain medication and or benzodiazepines?
I think it was pain. How much pain the patient's in, I guess, that's what I put. I think actually, I apologize. Or perceived pain.
And how do you determine that, and how does that affect your dosing decisions?
I think looking at the patient, what caused them to be in life support to begin with, what an overall view of what's going on with the patient at that point. I think examining the patient to get a feel for if they're in pain or not. Myself, I think that's the key.
All right. So in your practice, that is a decision you examine the patient and make a decision about.
Yes, I think that's an important role of the ICU physician, yes.
All right. And finally, you said family. Mm-hmm. Explain what that means and explain how that affects your dosing decisions regarding how much pain medication and or benzodiazepines they need.
Well, I think I did a pediatric residency also with internal medicine, and so I was always taught to look at the family as a unit from my pediatric training. So when I look at the patient and the family, they're a unit together. They're all kind of going through this together, and so basically I want to say when I stop back by, I always ask them, how do you perceive the patient's doing? How do you feel about how the patient, do you think that your loved one is hurting, or they should, you know them better than I do? I mean, the answer would be yes. If you need more pain medication, we can make sure of that. But obviously, their input matters in those discussions when I'm coming back checking on that patient.
All right. Do you recall the questions regarding the statement Ms. Menashe made in the question she followed up with? Two doctors with similar backgrounds and experience can have different views on how to treat a particular patient.
Yes.
Okay. And you agree that, yes, that is a valid thing.
In general, yeah, it's hard to argue with that statement, yes.
In particular, in this case, in 2015, how many years experience did you have?
I'm sorry, let's see, 2018 years maybe, if I exclude internship and residency and fellowship, so.
In 2015, how many years of experience did Mr. Husel have?
He'd have 2 years at that point, if I did the math correctly for him.
James Allen, I think we've determined was 80 years old.
Yes.
So that would be one of those factors we just talked about that would, in your experience, he would need less pain medication.
Yes, with his heart and liver, yes.
And he also,
Opinions again?
based on his practices, his dosing.
Well, he also treated the person involved as this witness not permitted.
And you also said, based on what you treated him on and what you were crossed on, he had significant health issues and limited pulmonary performance.
Yes, he had pretty severe COPD and got short breath walking very short distances.
And so in your experience, is that one of those things you look at deciding to give more pain and benzodiazepine medicine or less pain and benzodiazepine medicine?
Objection, Your Honor. Same objection.
Same, I understand. I think you can answer it. Go ahead.
I would probably wind up giving him less at that point.
Ryan Hayes, the overdose situation, down for a long time. That line of questioning, remember that?
Yes, sir.
I don't know if it was Ms. Menashe or you, state of peril on 4217.
I'm sorry.
Do you remember that phrase being used in describing Ryan Hayes? He was in a state of peril on 4217.
I don't remember that. Almost
Okay.
all my ICU patients are in a state of peril.
Yeah, I guess so. But he had been down for a long time, correct?
Yes.
He had a severe cerebral edema.
Yes, the brain was swollen. Yes, the top part of the brain.
Your note reflects that based on your experience with this patient, he cannot perceive pain, he cannot perceive anxiety.
That is correct.
Based on your experience in dosing patients in this state, is that one of those factors where you would give him more medicine, pain medicine and benzodiazepines, or less?
Less.
Ms. Belisari, do you recall how old she was?
No.
69, 69, exactly. Is it 69 she was?
She told the jury so I think that's good.
Let's see. If the records reflect, we'll get to it here. She was born in 1945. So in 2015, how old would that make her?
70.
Okay, he's here as a doctor.
I know, and I'm sorry. So that's 55 in 2000 and then plus another 15, so that would be 70 years old approximately.
Yes, sir.
I think the medical chart said 69. But
All right, she hadn't had her birthday yet. So once again, and not, is that a person that's older in your mind or younger in your mind as far as the dosing of pain medications?
I wouldn't, I'd have to know more information. I don't know that.
Well, we know that Ms. Menashe pointed out to you that without life support, the patient would not survive.
Yes.
She was critically ill.
Yes.
Is that one of those factors where you think, well, I need to give her more medicine or less medicine?
Objection, Your Honor, he wasn't there. This calls for an opinion.
Okay.
He's already said he would have
Sustained.
no more.
Got it. Sustained.
You did cover the night shift a few times in the ICU in your career?
Yes.
All right. Do you recall ever doing palliative extubations at 1, 2, or 3 in the morning?
No, sir.
Why are you looking at those 5 factors in determining the amount of pain medicine and benzodiazepines to give your patients?
Your Honor, I think it's misstating the witness's testimony. It wasn't that there was just 5.
Okay. It's also asking him to opine, so
And that's in
sustained.
his practice, why does he look at
That
those?
wasn't what you asked him.
In your practice, why do you look at those 5 things?
Objection.
I'll permit the answer.
Because in medicine, you don't want to even be perceived as crossing that line of
What line is that?
Now you're getting into a different subject matter here.
All right, I'll withdraw that question and let him answer the question.
Which question?
Why does he take into account those in his practice, those 5 things he described on your cross-exam?
You don't want to be the physician that caused someone's death where you cross that line or even perceived to cross that line of causing their death with your medications. And you don't want the nurses or anybody to feel guilty about giving those medications either.
Thank you. I have no further questions.
Anything on the last statement?
Yes, please, Your Honor. I would also ask for a recross on 2 other points, if you want me to approach
Let's
sidebar.
approach sidebar. I know you all hate it.
Yep,
These guys love it.
seems necessary. Can I have the order set, please?
When I use the 17,
Great. 17A, offer my questions.
They will go entertain. They're quiet over there. I'm getting worried. All of them.
No, this is not the most critical witness in the world, but he was involved in the pulmonary treatment of these people involving like pulling out the tubes. So other than he's showing that some of these victims might actually have been dead at the point where Husel did his thing. So that's a very important issue because you can't kill a dead person. Yes, Don, that did come out on cross. So yeah, we're to the point of now asking different questions about treatment. Sorry, Rennie, we turned it down right away, I thought. So well, now we're back.
Doctor, just a few questions. If I may approach
With State's Exhibit 17A. Doctor, if you could review that. And again, sorry to say that in order set.
Yes.
If you could just flip through the 3 pages and let me know if there is any box within that order set to check.
Uh-oh. Like, damn it, we're freezing up again.
There's not.
Just stop myself.
Okay, I'm proud of you.
It's a little thing. You were asked a line of questions about Ryan Hayes and the 5+ factors you would consider when determining the pain medication for a patient like that.
Yes, ma'am.
Would it have impacted your decision-making in any way?
showing the witness what's been marked as Joint Exhibit 2, page 205, that 2 different nurses seem to have indicated that Ryan Hayes, the patient you've discussed, had a pain score of 10.
I apologize. I thought pain score went to 8. I apologize.
Right, and so, and let me look, Your Honor.
Wait.
Okay, so then I would just ask the witness didn't answer my question. Would it have impacted your decision-making in any way that 2 different nurses have indicated that his pain went from 0 to 10?
Knowing his physiological process at that point, I would have to come and look at him myself.
You would need to be at bedside.
Yes, ma'am.
Nothing
What's your
further, Your
third
Honor.
question, huh?
Nothing further. I'm always dancing.
Okay. You may step down. Do you have another witness ready for us? We do, Your Honor. Let's call the next witness.
Calling Dr. Caleb Wagner to the stand.
And Judge, with your leave, I'm going to step out
Okay,
just to.
make sure that the good doc gets out of here good. Or well, actually, if I'm going to be grammatically correct.
Here's the discharge.
You guys holding up okay?
And we have another seal.
Is it warm in here? It's just this row. Like the opposite? I am roasting up here, guys. It only comes in, you know, the heavy material. Come on down, doctor. Follow that gentleman there, and he'll get you to where you need to go.
I swear affirm to tell the whole truth and nothing but the truth, so help me God.
I swear.
Thank you. You can take a few seconds to see if you make yourself comfortable.
You can lower your mask, it's fine. I want you comfortable.
And if you would be so kind as to state your name for the record and spell your name, please.
My name is Caleb Wagner, Caleb Wagner.
Can you guys hear him okay? Okay. You got that aerial mic in front of there, you have to blow it out a bit. Okay? Knock him down.
I can do that.
Okay, deal. I expect no less.
Thank you. Thanks for coming this afternoon, Dr. Wagner. Can you talk a little bit about your education and training?
I did my undergraduate degree at Ohio State University, and I graduated in 2006 with a degree in the biological sciences. I went to medical school at St. Matthew's University, and I did my residency training in internal medicine at Mount Carmel West. I finished that in 2014.
Other than medical school, have you ever worked as either a medical student or a physician at any other institution other than Mount Carmel West?
After I finished residency, I did a brief stint at Adena Healthcare System, and I only lasted about 9 months there before I returned to Mount Carmel West.
Thank you. And sir, what is your position at Mount Carmel West?
I'm an internal medicine physician. I'm employed with a group named Columbus Inpatient Care, and the group I work with is contracted to provide hospitalist service in the Mount Carmel Health System.
Thank you. Talk to us a little bit about your role as an attending at Mount Carmel West.
Working as an attending, to give an example, our group of doctors function as something that like perhaps your outpatient family doctor would do, except we do it in the hospital only. We're all internists. Typically what we'll do is admit patients from the ER or direct admit patients from home with a variety of medical conditions, even sometimes some surgical conditions. Will still be the main admitting team sometimes. And we care for a variety of illnesses, so it's hard to describe just one.
What were your assigned responsibilities for a patient if you were designated as the attending?
Typically what that would mean is performing the H&P, monitoring their care.
Does that mean that the initials, the H?
Oh, the initial evaluation, we call it a history and physical examination. It's a long note where we describe why the patient came to the hospital, what they were sick with, what we felt was going on. We correlate lab findings, test findings along with that. We include a physical exam and as well as imaging. It also includes a synopsis of the patient's past medical history and surgical history. And then essentially the last part of our note is where we make the diagnosis for why they're in the hospital, and what our plan is going to be to start treatment for that patient.
Do your responsibilities vary depending on which shift you work?
They do. They can vary greatly.
Okay. Did the jury hear that, the question? And what shift do you normally work?
I work essentially two different shifts in the Mount Carmel system. I work what we call days and nights in our group. So I'm either what we call a daytime person, 7 to 3 time frame, where that can consist of either rounding on patients or just being what we call our admitter, where we admit all the patients to the hospital. And then I'm one of the docs in my group that does about 8 weeks of nights a year. And that is coming in around 11 p.m. to 7 a.m. And that role is admitting patients to the hospital, evaluating patients emergently on the floor if they're having new issues, and sometimes what we refer to as just putting out fires, maybe problems that are occurring that did not expect to occur, or new situations in the hospital, to give an example.
Thank you, doctor. Now, when a patient presents, how are they assigned an attending physician?
Typically, if most common example is patients will come through the ER. The ER physician will see them, evaluate them, and the ER physician typically makes the decision of, can you go home or do you need to be admitted? And once that decision is made, the ER typically contacts our group, and then we take over the care and go and evaluate the patient and start their hospitalized process.
Okay. And so just to summarize, it sounds to me like these patients aren't patients that you are seeing in the community. Is that correct?
That is correct.
Okay. Is there ever a continuum of care with them when they're discharged from the hospital with your group?
Typically, no. What's done is our care is handed off for the outpatient physician. Typically, they're often referred to as a family physician or an internist. We hand that off to them essentially at that point.
Okay. Do you, as an attending physician, have duties relating to the discharge of any patient?
Yes.
And what are those duties?
The duties of the attending physician at discharge are to, I'm trying to give an example here. So if someone is sick in the hospital with a heart attack, the cardiologist might do some of their emergent care and make recommendations, but the attending's job is to make sure they have their medications they go home with, that we write the note to, sometimes referred to as a discharge summary, which is a summarization of why they're in the hospital. And this note lands back with either their main doctor and the outpatient specialist they may end up seeing sometimes for a summarization of why they're in the hospital, and a synopsis of what they were cared for, what they were diagnosed for, and maybe what needs to be followed up or tests that might need to be performed in the future.
Thank you, doctor. If a patient is critically ill and is moving to a DNR-CC, is the attending part of that discussion typically?
Sometimes.
Okay. And what would determine whether the attending would be or wouldn't be?
That's a very situational question. Sometimes it can be done by the ICU team. Other times, if it's a patient on the floor who's not doing well and maybe doesn't want to go to a higher level of care like the ICU, sometimes that's where the attending would have that discussion too as well.
Okay. And would you expect as an attending to be called in that situation if you were in the building?
Not always.
Okay. And what would drive that?
Typically, if you want to take an example, if I'm covering nights, typically it's if a nurse contacts me with something, say it's a floor patient who's not doing well, they would ask me to come evaluate the patient, and then either the patient or family might have a different desire, and that's where we would start talking about code status and how aggressive to be, and we'd have some of those conversations centering around a DNR.
Okay. If a person's on life support and withdrawal of that same is being discussed, would you be in the discussion?
I've had that discussion before with families. It's usually when I'm a daytime physician, I'm calling it, where I'm rounding in the hospital, seeing patients. That discussion also happens a lot with our ICU team as well.
Okay.
And there are other services at the hospital, like our palliative care service, that sometimes helps us assist having those discussions because they're not easy discussions to have.
I'm going to hand you what's been marked as State's Exhibit 6B. Dr. Wagner, what is 6B?
The 6B is a discharge summary.
Okay. And is there a patient indicated on the discharge summary?
Yes, this is for patient Francis Burke.
Okay. And I see that according to this, Ms. Burke was apparently discharged 1/14 of 2018. Is that correct?
Correct.
Okay. Here's page 1, second half. Page 2. And page 3. Can you tell us what page 3 denotes as far as this lady's status at discharge?
The page denotes that she's deceased.
Okay. Did you prepare this discharge summary?
Yes, I did.
Did you ever meet this lady?
No, I did not.
Did you review her entire medical record?
A brief synopsis of it.
Do you know what happened to her in the hospital?
From review of the chart, I'm aware of what happened to her.
Okay. Can you tell the jury what her course was?
She came in the late afternoon, and I was working our night shift then, and I would only be speculating as to why she wasn't seen by.
Okay, you can't speculate about something, so we're gonna stop you where you're at, and we let her ask more questions for you.
Okay, I'll withdraw the part of the question that calls for speculation. Did you review the medication administration record in this case?
I reviewed it when I was summoned to hear.
Okay.
That's when I saw that.
Did you review it before you created the discharge summary?
No, I did not.
Okay. Sir, I'm going to hand you a document under seal marked
Objection, Judge.
State's Exhibit 18F.
Let's go talk here. Talk, guys. David, you need to give me a recipe for baklava.
Okay, guys, if you can hear anything, that's great. I can't hear crap right now, so I have to fix this.
In this case, it's,
Never mind.
she explained what it was. Okay, well, I don't want you getting the wrong impression of the word seal. Okay?
Actually.
Duh. That's why we couldn't hear. Good job,
What did I
Doug.
get wrong?
I'll withdraw the request. Did you sign this?
No, I did not.
Okay. Did you prepare any forms for a death certificate for Francis Burke?
No, I did not.
And why is that?
I never saw Francis Burke.
Okay. And does that create an impediment as far as creating the death certificate?
I never did an exam on her. I never saw her. And this occasionally happens. And sometimes the death certificate is sent off to either the family doctor or someone else.
Okay. Do you know who did the
Conspiracy.
death certificate in this case? Do you know that individual?
I do not know that individual.
All right.
He's got a snazzy tie, though, I will say. I like that dude's tie. I'd love to have that tie. I wonder where the hell he got it from, because that is actually kind of nice.
Dr.
Like, no
Wagner,
joke.
One question relating to your previous testimony about the MARS at the in real time. Was there some reason why you didn't look at it?
I had no reason to question her medication she was given.
Okay.
There you
And
go.
just for the record again, the MAR is what?
Medication administration record.
Okay, thank you.
Mr. Baez?
Good afternoon, Doctor. You have no independent memory of when you actually did this discharge summary, correct?
No, I do not.
In fact, you didn't even look at it or have any idea that this was ever going to be an issue until you were called to testify in this case?
Correct.
And obviously, since you never saw her, you don't have any memory of Ms. Burke or her care.
No, I can really only comment on what other doctors documented.
And fair to say, some discharge summaries are more detailed than others, right?
Very, very fair to say.
Okay, and that's just like patient, that's just like patient care. Every patient is different. Is that a yes? Yeah.
Yes.
Say yes for the court reporter.
Yes.
Okay, so, and in this one, you would classify this one as one of the lesser detailed discharge summaries.
This was a very atypical discharge summary for me.
Just pointing out, he never did anything with it.
There was never anything preventing you, when you did this discharge summary, from looking at the MAR, looking at.
He thought nothing was abnormal.
The electric, it's like electronic medical records in Ms. Burke's care.
No, nothing prevented me from looking at it.
And there's nothing, and you never sent a notice to anybody, hey, I never looked at any of this stuff when I wrote my discharge summary, correct?
It's not normal to do a forensic review of the chart for a discharge summary.
But my question to you, sir, is you never notified anybody, any doctors, anyone in the hospital, hey, I didn't look at the MAR or I didn't look at any of the charts.
Well, I did look at her chart.
Excuse me, I'm just looking. You didn't notify anybody that you didn't look at it, correct?
I guess I'm not sure how to answer that. I don't
Okay.
normally notify anyone if I,
Right, you wouldn't normally do that, right?
no.
And that's not something that is in any way, shape, or form the normal course of business, right?
Can you ask that again?
Sure. That's not in any way, shape, or form the way you would normally do a discharge summary.
Normally when I do a discharge summary, I've usually been involved in the care at some point, and typically I write much more than what I wrote in this discharge summary.
I have no further questions.
Redirect? You can step down.
Sorry,
Sorry, Judge.
sorry,
I forgot to. May I
that was me.
check, see if I have one more question?
Do you have one more question?
Sorry about that. Get a little fired up there. Let me fix that. How about that? Is that better?
No further questions.
No further questions then?
No, Your Honor, thank you.
You may step down, doctor. Thank you. Call your
Your
next
mom's got
witness.
further questions.
I believe we're out of witnesses for the day, yes.
I have a feeling they're going to call every doctor who signed every death certificate at this point for all the murders. I think they have to.
I guess we were more efficient than anticipated. Ladies and gentlemen, I'm going to have to send you home early. I'm sorry. I know you want to sit here with us the rest of the day, but, remember the admonition. Be sure you all speak to David about the other issue. Okay? I imagine I'm going to have a bunch of emails tonight, so let us know, guys. Okay? With that, calm up, David. Have a good evening, guys. Be safe.
I think they're going to have to do that. Yeah, they're done for the day. Yeah, Seabreeze, I think if they're going to try to do every doctor who signed every death certificate, that's going to be weird. That's going to drag on. I have a feeling a lot of them are going to be, they died, and that doctors looked at it. Yeah, I looked at the chart. She's dead. Boop, death certificate, and they checked it off and left. Like this doctor said, I didn't think there was anything. It was atypical, but look, she's an old lady who croaked, was sick and in a lot of problems, so she died. That was it. I think yes. Husel's out on bond. He's out on a $1 million bond. He's been out on bond for a while. So yeah, I think there's this is another one where they're just pulling apart, once more, just a little bit more unraveling. Doctor didn't think anything was suspicious until he got told something was suspicious. Okay, Matthew, I think that Jose Baez is going to be pulling in a lot of nurses and a lot of pharmacists. I think where you're going to see where there's some gaps in this investigation, they're going to be bringing that up. Or they might not be. I don't know. The state certainly won't be doing that. Because it's already been established in testimony they didn't do that. So, I hope that makes sense. But yes, guys, in case you're wondering, the lady in charge of the convoy, the trucker convoy in Canada, was finally granted bail under decent conditions, finally. It's insane that happens up there, but Canada does things different. That's how they roll. But she finally got granted bail. So, some good news today. Ooh, I got an email from who? Ooh. So yeah, do you guys have any questions at all? Huh. So curious to see what you guys are thinking so far. I mean, Rennie's sleeping right now. Yeah, Seabreeze, like I said, thanks for coming by. And if you like this, like and subscribe. I do these as much as I can. I work around my schedule. I am a practicing attorney, so I don't just if I can be here all day, I will. But a lot of days are going to be like today, where I'm running around with the chicken with my head cut off. I do a live show every Thursday night at 9:30 for you. That's probably like margarita hour, so you'll probably be available. And then I try to watch videos in the meantime. Try to put out videos in the meantime. What was my very first trial? My very first trial I was a second chair on because I knew an attorney in Toledo, and I was just asking around, hey, can I do a trial? And she let me tag along, and the guy who was involved let me tag along. He was charged with breaking into a lady's house. Yeah, this one's a fun one. I can talk about it because I'm not going to tell you anything he said. So we get ready to do the trial, and the trial is basically this. Him and his buddy were running up at people's houses out in the countryside. Kick in the door, run in, steal crap, and then leave. Well, they happened to do this, and the homeowner, the woman who lived there, came home and stumbled upon them. So they encounter her in the stairwell, and they bulldoze past her. They run her over, which then becomes aggravated burglary because now it's burglary with violence. Now, they just knocked her over, but it's still violence. They run out and start loading all the crap in the car, and she comes out holding a cell phone. And they bent their license plate up to get it out of the way. And one of them walks over, not my client, the other guy, though, and starts beating her senseless. Basically grabs her by the shirt and just bop, 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 till she drops her phone, and they take it and smash it and then take off. So he had a aggravated robbery because they stole her phone and took it and destroyed it, and an aggravated burglary. He wanted to go to trial. We were doing really good. We got through jury selection. We got through a couple things. I got to do some questioning of some of the detectives and some of the smaller level people. That was a good way for me to get used to it. And then the victim finally got on the stand. And she gets up there and starts crying and says, "That's him. That's right there. He's the one who did it." And the trial stopped because he wanted to plead. That reinforced something I learned a long time ago, and that's everybody wants to be a gangster until it's time to do gangster stuff. You could say you'd rather be tried by 12 than carried by 6. You could say you'd will take your chances in front of a jury, but when that prosecutor points like this, it says that right there. That's the bad man, everybody. Look at him. Look at the bad man. He's guilty. You need to find him guilty. Once that happens, unless you've got ice water in your veins, you're gonna squirm a little bit at the very least. So just something to think about. I have a whole lot of other ones, but we can talk about those other days. Also, Seabreeze, if you came from long crime and those copyright abusing dickheads, don't be afraid to go snipe some more friends too. They deserve it. I tell that story and nobody laughed or thought it was cool. Aw, guess it wasn't that good. I'm just screwing with you guys. Do you think Curtis Reeves is squirming? No. I don't think so, because unlike a lot of people, he had been in court before. He had court experience. Also, I think he was old enough. He just didn't give a fuck. I mean, how much longer is he going to live anyway? Also, think about this. He spent how many years having to, even if he thought he was justified, how many sleepless nights, how much worrying, for 8 years. Think about how much time that took off his life worrying about this, especially as an old man. I mean, I could see him, he could croak 6 months from now and I wouldn't be surprised. That's a lot of stress to eat, especially at that age. Yeah, that one was messed up. I don't, I will say this much though. I think from that enhanced video, there's enough reasonable doubt whether or not, the state can't prove their burden. And based upon, those hands flying, I can't say that he wasn't in fear of his life. So, Chad got chatted. So, kind of life story. Don't be like Chad. Law and crime chat is really tense. I don't know. I've looked over there once in a while. That seems pretty boring. But if it's intense, bring people over because I'll show you guys tense. Especially if we think there's going to be like a mistrial. The judge in Curtis Reeves' case, was she a nutcase? No, I don't think she was a nutcase. Judges are like anybody else. Some of them judges are pretty standard, but you get eccentric ones one way or another. You get ones that are super, super strict, and you get other ones that are kind of like just like, ooh, kind of a little flaky. It just happens. So I don't think she was a nutcase at all. It's just the way that's by far from the worst judge I've ever dealt with. Could that judge be frustrating at times? I bet, but I bet there's other times where it's actually very helpful the way she does things. So just also remember this is probably like the biggest trial she's ever done. Most of these trials when you're dealing with a murder, it's going to be 3 days, 4 days. George Zimmerman wasn't even this long. Well, that's not uncommon. Judges not necessarily knowing the law as well as the attorneys involved because the attorneys know their case front to back and have been focusing on this. This judge has got, maybe she's got another trial next week. I mean, this is one in a sea of thousands she's dealing with. So, yeah, Seabreeze, there's fighting here. I mean, there's really no rules. This is kind of like Somalia. You could do what you want, be nice to each other, but if you're going to fight, you can talk shit, come my way. That's the only real rule I have. So, what kind of case would I prefer to try a case in front of? Laid back like Chew or Op? Who's Op? Would I try it in front of OPP? I mean, I'm down with OPP, so that may help me. Or opposite like browsing. What? I'm confused. Oh, Borowski. Yes, Christopher. I would rather have Christopher. I would rather have Borowski because I know what I'm gonna get every time. He may be a dick, and I don't think he is. But there are some judges out there who are just big assholes and dickheads. At least they're always assholes and dickheads, and you know how they're going to act every time, and you can prepare and anticipate. If you notice, the prosecutor had been in front of him a bunch, so he knew how this played out. So he was always ready, had his shit together, didn't mess around, crossed his T's and dotted his I's, was ready to roll. There's nice that had that consistency. I haven't been in front of a judge that's as outspoken as Judge Borowski, but I've been in front of one who has very high standards. The other thing a judge who's got very high standards is it forces you to be better. You have to meet those standards. I will say the judge I was in front of, he's probably one of the best judges I've ever dealt with. Extremely smart, highly intelligent man. I appreciate what he does because it forces you to be better. I would also say, his writing. When he would write an opinion, he's very deliberate, and it's not even academically focused. He's practically focused, but he supports it with good scholarship. So, and I don't ever want. He's still on the bench, so I don't know. I want to name his name, but phenomenal judge. He's in Western Ohio. Impressionist, I mean, it is like Somalia. I don't care. You could say the gamer words. You can say whatever you want. I'd rather see you guys not fight each other, though. If you want to fight, come see me. We'll talk. I ain't afraid to fuck around. Also, it's my channel, so I do whatever the fuck I want. So. Yeah, and that's the thing. All judges try to make jokes with the jury. They all try to have a rapport. Some are good, some are bad. Judge Borowski, yeah, he can kind of do it, but he comes off as the blue collar guy. But all judges have their way. There was a judge I dealt with once who, he was a visiting judge, so he was retired, but he fills in when judges aren't available, or if there's a judge resigns and there's the vacancy till they can fill it. We were in trial, and he was talking to us on the jury about when he tried his first murder trial in 1968. So some judges are really good at telling their stories. The judge in that one, yeah, but I mean, when you get to the point you're dealing with like Chandler Halderson or something like this, it's going to be a sideshow. You can't. There's only so much you're going to be able to do to control the flames of the forest fire. It's going to burn. You can handle it the way he did, and I think he did a very good job at it. But there's only so much you're really going to be able to do with a case like that and control it. That's really going to come down to the attorneys, and I think the attorneys did a very good job at controlling it. Now, I have a theory that, I understand like Ricada and all those guys think they phoned it in to an extent. And I think they did, but I think the issue was he told them, "You're not going to attack my girlfriend and pin this murder on her." And part of client management is what you do. Other than all caps and the fake swearing, like I said, don't be attacking each other. Other than that, come at me with whatever you got. You want to call me a fat fuck? Fine, let's go for it. Let's tango. But yeah, that's those are their rules. Oh yeah, fuck their rules on law and crime. But Borowski, it's not that he was no nonsense. It's just I can tell you every day he's gonna be that way. Every trial, I could walk in there tomorrow and try a case. It could be just drug possession. He's going to be that way. He's going to treat me the way he treated Ivory Lamar if I come in there and act like Helen Keller, as he should. But I will state right now, that doesn't say Judge Chu isn't the same way. I don't know if she is. I assume she's fair and partial and gives everybody a fair shake. I have no doubt that she does. And I will never assume that she doesn't until proven otherwise. But I appreciate knowing with Borowski, I can pretty much guarantee what to get. Like, just by watching, I kind of have an idea. I assume he sets a lot of discovery deadlines. He sets deadlines in advance, doesn't do too many pre-trials, doesn't jerk around a whole lot. If you're going to do a motion limiting, he wants it ahead of time. Yeah, I assume there's a lot of stuff for him he's ready to go on. So, yeah. So that's why I would start there with him. I would say she's a coward because she didn't do the right thing for Kim Potter, but that doesn't mean that how she handles cases otherwise. I will say when the cameras are on her and the chips are down, Destiny comes for us. Destiny comes for us all at some point in our life to make the right decision and to make the big call. It came knocking and she didn't, and she punted. So, Seabreeze, which channel are you talking about for this trial? Seabreeze, I'm going to try to have this up every day for this whole thing. I'm going to try to ride this one out. It's going to be a little tough coming up in the 8 weeks because I do have trials in the meantime, but Oh, but I'm going to try to go for the whole thing. Seabreeze, there's also I hope that answers your question. Well, and here's the thing: if I'm not able to be here, Rennie is able to help. She's TX Packet. She tries to help, and she helps kind of get stuff going. Also, the neat thing is, I figured this all out. I can set this up from my phone, and I didn't know that, but that's a really cool thing I can do. I was playing with that before. I think last week you saw me popping in and out all the time. I can set stuff up through my phone, so like I can be already at the office or like already in court, and if I have something happen, I can fire it up and it's good to go if Rennie's not available. Because she's out in Colorado, so a 9 o'clock day for her is pretty early. She's got her own stuff going on. So, yeah, I have ways of doing it. But yeah, Seabreeze, like I said, I do a Thursday night stream, so you'll be available. Because I'm sure it's only like noon there, 1 o'clock. Actually, it's probably even worse. It's probably like 11 o'clock or something. Yeah, we talk about things, and we've got an interesting one for this week. We're going to be reviewing a YouTube video. And hopefully I got some receipts by then. If not, we'll have to postpone that. Where's Gabby? Gabby had to take off. She had some things going on. Oh, yeah, Borowski would not have given them 3 hours for Reeves. Although Reeves is a lot bigger. He might have. That was a big case. A lot of witnesses. I mean, you never know. Yes, this is NBC4 out of Columbus, Ohio. So if you Google William, Husel trial, and you know what? Actually, hold on, Seabreeze, and all you guys, since you're curious, I'll throw this up in the link. I'll throw this up in YouTube. That way, well, I hope you guys don't blow me off and start using this instead. That'll kind of suck. That would be kind of embarrassing if I. So give me a minute here, and I'll put this together. I will say, if you guys are looking for a good TV series to watch right now, Pam and Tommy on Hulu is phenomenal. Very, very good. I would highly recommend it and go from there. It's pretty cool, especially for somebody like me, because I was like 9 years old when this whole thing happened. So I'm sure a lot of you are going to be panicking then. Oh my gosh, he's not even that old. Yeah, deal with it. But yeah, here, hold on, guys. I am working on this right now, so you guys are going to be all set. I just put the link in the description of where I go to get this. Channel 4 out of Columbus has the best quality feed, in my opinion. So that's why I use them. Uploading a thumbnail. Save. Oh, stop screen. Yeah, there we go. All right. So, I have notifications set up for this channel. Thank you so much. Oh, we do move clocks up 1 hour ahead this coming Saturday. Fuck. I hate that. That's, I'm not going to lie. Fall back on the 4th of July and fall back are like the two best holidays in the country in a year. I mean, I'm 36 actually, but yes, I'm like 35. So, yeah, born in 85. So for a lot of you, that's probably, you're going to be like, I remember I was doing the jitterbug in 85. Like, and I bet you were. I kid though. I kid. Well, thank you for reading Facebook. Yeah, if you like me, refer me to your friends. Well, like I said, let's take over Law and Crime. Let's get to the point where Dan Abrams bends the knee to me. That'd be hilarious. Could be Sean in Crime. I want to stay on DST. Dennis chewed up my lip. Oh, if he chewed, like, did he chew it up with his own teeth or what? Oh, and it cut my lip all up inside. Ah, I hear you. Okay, the way you said that initially, I was like, sounds like you have a really kinky dentist. Yeah, stay on daylight saving time. I know I would too. I don't want to go back. Yeah, guys, so that's it for right now. I mean, we'll be back tomorrow morning. You will not see me. I'm gonna be if you guys do that, that may be something you can do. I will be in and out. I'm actually got a lot of things I got to do tomorrow, so I'll be at my office. I may poke in. Seabreeze, I don't know if I mentioned this before, but I'll poke in on voice at times, just the voice, and I'll be a headless body. I got to work on what to do for like my stop camming face. This thing here, I got to figure something out for it. Some art or something. I don't know. I'll figure something out. Who knows? Also, yeah. You guys got any questions about anything? Like I said, no such thing as a stupid question. Yeah, no, you guys are welcome. I enjoyed it today. So, yeah, guys. So, yeah, that's it for today. If there's something else going on, you guys go have fun with that. But yeah, I'm gonna take care of some stuff and got some house cleaning to take care of. So, I will see you guys tomorrow morning, 9 a.m. Have a nice day.